optimal postprandial glycemic control because the insulins are slowly absorbed, inconvenient timing of injection because they have to be the conventional insulins have to be injected 30 minutes before meals, longer duration of action causing interprandial hypoglycemia, and lower quality of life because injections and meals must be planned. So it's a rigid system when one uses the older types of insulins, whereas the flexibility can be achieved with the use of the modern insulins. So this slide here demonstrates the fact that the insulin onset of action is delayed, and the peak is lower and later. So there's a period of hyperglycemia shown in purple, which is a period of unwanted hyperglycemia, and in orange is demonstrated the period of unwanted hypoglycemia. So using conventional insulins, one has hyperglycemia because the insulin has not started acting, and when the insulin is acting, the blood sugar levels are already dropping, and therefore you have hypoglycemia. So there are swings of blood sugar between hyper and hypoglycemia. So with the use of conventional insulins, we decrease the dose, it causes elevation in blood sugar and increased risk of complications, and when you increase the dose, it causes risk of hypoglycemia. So the balance is not achieved. So that brings us to the modern insulins or the newer insulins. These are molecules which differ by one or a few amino acids from the primary structure of the human insulin molecule, and they were developed to provide more physiological replacement after subcutaneous injection than human insulin, and it was made possible by the advent of recombinant DNA technology. We have these three groups: the rapid acting, the long acting, and the premixed. This slide demonstrates the rapid acting modern insulins. RAMI stands for rapid acting modern insulins. The molecular structure of lysproinsulin or Humalog, which you can see is a modification in amino acid 28 and 29 of the B chain of the insulin molecule, and insulin Aspart, which is a modification of amino acid 28 on the B chain of the of the insulin molecule, and insulin glucosylation, which is not yet available in India, where there is a modification of amino acid 3 and 29 on the B chain of the insulin molecule. So the rapid acting modern insulins mimic the physiological profile of the natural postprandial rise in glucose or rise in insulin, and they provide a bolus for postprandial blood glucose control. The advantages are many. They mimic the physiological insulin profile. They have a faster onset of action than the regular human insulins. There is improved glycemic control, and the effects are predictable. Now we come to the long acting modern insulins. The molecular structure of glargine, which is, you can see modifications on the amino acid 21 of the A chain, and addition of two arginine molecules on at the end of the B chain. And this is a molecular structure of detamere or levemir insulin, where there is an additional myristic acid or a fatty acid which is attached in lieu of the amino acid of B30 of the B chain. So the time action profile of the long acting modern insulin, there is no pronounced peak of action. It has a 24-hour duration of action depending on the dose that is used. And the uses of these long acting molecules, they are used as basal insulins. They can be combined with oral anti-diabetic agents in the treatment of type 2 diabetes, and can be used with the regular human insulins or the rapid acting modern insulins for treatment of type 1 or type 2 diabetes. The advantages are several. It fulfills the basal requirement of insulin. The rates of hypoglycemia in the middle of the night, nocturnal hypoglycemia, are much lower compared to that used with NPH. It has a 24-hour duration of action for most patients. There is consistent blood glucose response, there is less weight gain, and it is designed to mimic the physiological insulin profile. Therefore, a combination of the short-acting modern insulins and long-acting modern insulins plays an important role in the management of type 2 diabetes. This slide just amplifies what we have discussed. The onset of action of a regular human insulin molecule is 30 to 45 minutes. Therefore, it needs to be injected about half an hour before taking the meal, whereas the onset of action of the rapid acting human insulin, the modern insulin, is just 10 to 15 minutes. So you can give the injection about 5 minutes before the patient takes the meal. So this is one such rapid acting insulin analog, insulin Aspart or NovoRapid. And compared to ActRapid, you can see there's a definite improvement in the pharmacokinetic profile, which is a better pharmacokinetic profile, which we have discussed in the previous slides. This really demonstrates the action of the rapid acting insulin analog versus a regular human insulin molecule, we can say the rapid onset of action, a peak action which is much faster in terms of time, and a rapid decline in action, so preventing hypoglycemia during this period of time. And the pre-mixed modern insulins, they have a better short acting 30%, which prevents hyperglycemia postprandially and matches the natural physiological insulin secretion, thus giving a better blood glucose profile. So the modern insulins compared to human insulins provide mealtime flexibility, rapid acting insulins, superior postprandial blood glucose reduction, better glycemic control, less variability in the blood glucose levels, less hypoglycemia risk, less undesired weight gain, particularly with Levemir, available in easy to use pens with painless needles. So having discussed what the regular insulins and the modern insulins are, we shall now come to the insulin regimens and insulin administration. The non-intensive insulin treatment is one type of insulin therapy which is used most often in type 2 diabetic patients. It is not recommended for patients with type 1 diabetes, especially useful when oral anti-diabetics fail in patients with type 2 diabetes. And the non-intensive once daily regimens use NPH insulin or the long-acting modern insulins or premixed insulins. This is one example of a once a day insulin regimen where premixed insulin can be given once a day before breakfast, where the short acting component covers the breakfast peak and the intermediate acting can cover part of the day, and the rest of the pattern is taken care of by oral anti-diabetic agents. It provides better but not optimal glycemic control. The dosing can be before breakfast and before dinner, or before breakfast or before dinner, and coverage of glucose peaks best for breakfast and dinner, sometimes for lunch and for dinner. So the non-intensive twice a day regimens include NPH long-acting insulins or premixed insulins. They can be used twice a day as well. Like in the previous slide, I demonstrated once a day insulin. Here the same regimen is used twice a day, once given in the morning before breakfast, once a day before dinner, so giving a better 24-hour control of blood sugar. So that was about non-intensive insulin treatment. Now we come to intensive insulin treatment, a brief overview. And there are two methods of achieving intensive insulin treatment. One is by multiple doses of insulin. So in the previous non-intensive treatment, you've seen that only 1 or 2 insulin injections are used, but in multiple doses of insulin or continuous subcutaneous insulin therapy, we match the insulin dose to self-monitored blood glucose levels, and overall this is a better way because it mimics normal physiological insulin secretion in between meals during the night time and the meal-stimulated bursts of insulin. So the intensive insulin treatment is recommended for patients with type 1 diabetes. It offers flexibility, doses are adjusted to activity and food consumed. The risk of hypoglycemia of course increases, and that's a consideration in type 1 diabetic patients. It also causes weight gain, and that's another important consideration. So the risks of intensive insulin treatment include risk of hypoglycemia and weight gain, and of course one has to monitor the blood glucose. SMBG stands for self-monitoring of blood glucose, which has to be done frequently, and that is mandatory because you want to prevent hypoglycemias when you use intensive insulin treatment. So this is a demonstration of what is called as the MDI or the Basal-bolus regimen, wherein red is demonstrated the 3 shots of short-acting or the rapid-acting insulin analogs which are given in combination with, in the green lines is demonstrated the 2 injections of either intermediate-acting insulin. So in effect you're having 5 injections of insulin. Or when you use modern long-acting insulins, you can use 3 shots of the rapid-acting insulin analog before breakfast, before lunch and before dinner, and one shot of the long-acting insulin. As you can see, it has a 24-hour action starting here and ending overlapping with the previous day's insulin dose. So intensive insulin therapy, what is known as the continuous subcutaneous insulin infusion, or what is also called as the insulin pump, is recommended for motivated patients who are very keen to use or to achieve better blood glucose results. And insulin pumps use only rapid acting insulin analogs, which acts both as a basal insulin as well as a basal bolus insulin, because it is infused continuously The basal insulin infusion is programmed into the pump computer, and bolus doses are infused 3 times a day at meal times, and this timing is set by the patient himself. So this is a demonstration of a pump, a continuous subcutaneous insulin infusion, where this is the basal infusion which can be preset by the computer in the pump, and this is given at a constant rate or at different rates at different times of the day. And these dotted lines demonstrate the boluses of insulin which are activated by the patient himself in response to a meal, which can be 3 times a day or indeed 4 times a day as required by the patient's meal pattern. Now, commencing insulin therapy, insulin should never be used as a threat to the patient, because fear of injecting is a common problem, and needle phobia is a rare fear of injections is extremely common, and it is the healthcare professional's attitude which is the key to the acceptance of insulin by a patient. We are very familiar with the resistance that patients show to the use of insulin. People should be praised and encouraged to promote a positive attitude, and blood test is more painful than insulin injections. That should be told to the patient, because patients are not very scared about doing blood glucose monitoring, but they are more scared about taking insulin by injections, whereas on the contrary, insulin injections are virtually painless. They are less painful than the blood glucose monitoring that is done on the fingertips. So starting dose of insulin will depend on many factors. In type 2 diabetes, one can consider continuing oral anti-diabetic agents in combination with the long-acting insulin analogues. As far as giving injections is concerned, it should be given into the subcutaneous tissue. The skin of a very thin person may have to be gently pinched. Insulin can be at room temperatures is less painful, so when the insulin which is refrigerated to store the insulin is taken out, it should be taken out at least half an hour before injection so that it is brought to room temperature. The needle can be inserted at 45 to 90 degrees, 45 degrees for very thin people and 90 degrees for overweight people, or when using short needles. And swabbing with alcohol is not necessary if the patient observes the simple rules of hand washing before taking the injection insulin. The various sites of administration demonstrated here. The fastest site is around the navel in the anterior abdominal wall. The other areas which can be used are the buttocks as shown here, or the upper arm as demonstrated here, or the lateral and anterior aspects of the thighs, where of course the absorption of insulin is the slowest compared to the abdomen where it is the fastest. And it's important to rotate the site of injection around a selected area. Various insulin delivery devices, here we talk about syringes and needles and the pens. This slide demonstrates the use of various insulin syringes and the insulin vial, and this slide demonstrates the modern day insulin delivery devices such as the use of flex pens or various types of disposable pens and permanent pens where only the cartridges are changed. So they have made the use of insulin much easier in the treatment of diabetes. Insulin pumps, of course we discussed the continuous subcutaneous insulin therapy. Inhaled insulins had come into practice a couple of months ago, maybe last year, but it went into disrepute because of the risk of cancer of the lung. I think I've come to the end of my talk, and I hope I've covered most of your doubts which probably prevail in the treatment of diabetes using insulin.
Thank you very much, Dr. Sudhir, and I hope that you must be benefited, because Dr. Sudhir has given very brief discussions about the starting from the history, the molecular structure, the different generation of the insulin, like bovine insulin, human insulin, and mode of the treatment. But the most important thing what here I want to emphasize is the patient's education and as well as the relative who are going to stay with the patient. It is very important, because until unless patient is counseled enough, all the treatment modalities is going to be failed. So I hope all of you can implement all this knowledge given by these sessions, and the patient will be benefited, the quality of life will be improved. And with this we would like to end here, and we will again meet